So this is the last part of the recall discussion for the NEET SS 2023 surgical group, and I've tried to accumulate all of them, but to apologize, I have not been able to get the recollect or the recall of 5 to 6 questions, and 1 or 2 I have not been able to get a proper recall to give you the correct answer with the reference. So I have tried to accumulate. I have got up to 143, 144 questions. I hope it helps. So starting with the first question, that is regarding which is it true about leaf from many syndrome and the 3 common cancers is given. So the answer here is that is associated with soft tissue sarcomas, adrenocortical carcinomas and brain tumors. So this is directly taken from the table in Bailey. So in this the answer is C. Moving on to next, a patient with shoulder pain, so that means that he is on analgesic pain medication. So what is the diagnosis of the patient present with guarding and rigidity? So it is a very straightforward question. If this was the clinical scenario, the first thing what we will suspect is a peptic perforation, and so we would be going with the diagnosis of perforation peritonitis. Now there are 2 questions of SH, and many of you have been confusing between the 2 questions, and it is very much obvious. But what I have gone and what I've tried to differentiate between the 2 questions, so one is SH clinical scenario was given and true fact was asked. So according to this and according to the Bailey's image which is given, that is the middle cerebral artery or the middle cranial artery is the most affected, followed by the anterior communicating or the anterior cerebral according to the image. But as we all know that anterior communicating is most common, but according to this image given in Bailey, the answer should be middle cranial artery or the middle cerebral artery is most affected, followed by anterior communicating artery. Now most common paraneoplastic syndrome is asked. Now what I have gone through the various books and articles, and what I found is that it is associated with humoral hypercalcemia of malignancy 1. So A cannot be the answer. It is associated with a Cushingoid-like syndrome, so it is associated with more of hypokalemia, so even B cannot be the answer. And it is also associated with a SIADH-like feature, so it should be associated with a hyponatremia. So according to me, A, B, C cannot be the answer, so the best answer is D if that is a recall what has been given. But I have not been able to find a proper reference for this question. But what I can say is that lung carcinoma paraneoplastic syndrome leads to hypercalcemia, hypokalemia and hyponatremia. So we need to go and see the proper recall, or if you have reference, kindly share it with us so that we can also share to the other students. So moving on to the next question, that is a patient, young male, raised ICP, vomiting, CT scan showing intraparenchymal hemorrhage. I think there was some lateral ventricles also which were seen in the CT. There was an image. Now which is true statement? So usually intraparenchymal hemorrhage you cannot do operative, because what shots is given, what I found is that if you go and operate in this patient, sometimes you damage the axons. So it is better to just observe and maintain and reduce the ICP. So according to me, that should be the answer, because you cannot do EVD in emergency department in this patient. You cannot do endoscopic clipping in basically IPH, and lumbar puncture should never be done in this patient. Basically, it will not help you. So according to me, medical management for reduction of ICP should be the answer in this question. Patient mostly having a hyperparathyroidism like picture. If the intraoperative image was like this, what has been shared by the students, which was showing a normal thyroid gland with some parathyroid enlargement or a parathyroid swelling, which is pointing more towards the parathyroid adenoma than hyperplasia or metastatic or diffuse thyroid enlargement, because according to the student, the thyroid is normal. But I think the image-based questions can have a biased recall. So if you feel the recall what I'm telling you is having incorrect answer because of the image what I've given, if you can share the correct image, please let me know, so that after this recall session is completed, I will be sharing the completed 150 question PDF or the 145, whatever I can accumulate, with the correct answers and the correct image recall. So it would be better if you can reach out to me in WhatsApp, or you can just mention the link of the image in the comment section. It would help. Inguinal undescended testes question regarding processus vaginalis, and I have not been able to find a very accurate reference in either of our books, but what I read online is that processus vaginalis, usually it gets obliterated, what we commonly see while the testis is descending. But usually if in undescended testes there may be presence of processus vaginalis, which is associated with inguinal congenital hernia. So according to me, the answer should be that it may be present. Now it is not always absent, it is not always present, and if it is present, it is not always present if this is the correct recall. So according to me, the answer should be it is may be present. Coming on to next, patient with a left PUJ obstruction, pyeloplasty done with fever, pain, showing left dilated renal pelvis, that is hydronephrosis. Next line management usually is always a drainage, that is either by stenting or a PCN. Now according to the option shared, you do not do ureterocalicostomy, that is connection of the ureter to the calyx. You do not do a rhodopyloplasty immediately. You do not do a resection. Basically, you go and do the drainage procedure for it to resolve on its own. That is conservative line of management, but with the help of either a PCN or stenting, depending on what the option was in the exam. Moving on to next, a patient with a foot ulcer, scratching, rupture with formation of ulcer, and the image shared was something like this, that was suggestive of a malignant melanoma. Now according to the recall shared, if it was a very huge ulcer and swelling ulcer like this with blackish picture, that is suggestive of a malignant melanoma. You cannot do a core biopsy, you cannot do incisional biopsy, you should always go for an excisional biopsy. Even if it is a malignant melanoma or something else, you should go for an excisional biopsy according to my opinion. Moving on to the next question, that is middle-aged female patient with complaint of swelling of the neck. It moves with deglutition but not on protrusion with tongue, so it is a thyroid swelling most probably. Single swelling, rest of the thyroid is normal, neck nodes are not palpable, so it is most likely a solitary thyroid nodule. How can you show it? So it is basically a single swelling, rest of the gland is not palpable. That is a typical feature of a solitary thyroid nodule. Now you can see that I have not been able to give a proper reference from any textbook, because to be honest, we are not able to find accurate reference for any textbook, because some of them are very clinical oriented questions and some are taken from the specialty books maybe, or from a specialty surgeon, and so we are not able to find accurate reference. So pardon me for that. I have tried to accumulate as much as references as possible for you so that you are clear with the answer. Now, not responsible for late enophthalmos. So one is that when edema occurs and it resolves, then enophthalmos can be visible sometimes. Orbital floor collapse, so obviously it will lead to enophthalmos. Ocular fat pad loss will also lead to enophthalmos, but atrophy or of extraocular muscle will never lead to an late enophthalmos. The causes are either increased volume, herniation, orbital fat atrophy. Fat atrophy can lead to, but not the extraocular muscle atrophy, so the answer should be that. Patient, young 3-month-old with tilting of neck with presence of tumor, that is most likely sternocleidomastoid tumor, that is most likely fibromatosis coli, which is also the terminology. So the most appropriate management for this scenario is always physiotherapy, and it should be begin as early as possible. So here neck swelling or mass can be diverse, but usually if it is associated with a tilting of neck on one side, it is usually fibromatosis. So usually do physiotherapy according to the reference what I've got in the online articles. What is proto-oncogene? So it is basically before oncogene. So it is a gene which is normally stimulating growth of the cells, but if it undergoes some modification and then leads to development of cancer, it is known as a proto-oncogene. Lumbar puncture with presence of or on treatment of low molecular weight heparin with loss of continence and lower limb paralysis after 36 hours, so most probable diagnosis. Now is as it is localized in the region below the level of lumbar puncture, it cannot be traumatic subarachnoid hemorrhage, because you are done a lumbar puncture, it is always an epidural hematoma. So it is a very logical and clinical acumen based question, so I don't have a reference for this. Moving on to next, a patient with upper abdominal pain, jaundice and GI bleeding. So jaundice and GI bleeding, and according to the options what were given, the most probable answer is hemobilia, not bilhaemia. So the answer here is hemobilia. Moving on to next question, that is aorto bifemoral bypass image that is shared by you guys, that it was a aorto bifemoral bypass with what is true. So the correct answer in here is posterior peritoneum is always closed over the graft to prevent the graft leak may not be there, but something to prevent any fistula formation. Midline is transverse incision is sometimes preferred, and there are varying results according to what has been given in shorts. Heparin is given always before the clamping of aorta, not after the clamping, very much obvious. And the tunnels are made in retroperitoneum and not in the intraperitoneum, so C is also not the answer. So the best answer is D, that is posterior peritoneum is always closed over the graft. You do not keep it open in communication with the peritoneum. Now this is a question which I have not been able to figure out the exact question or the options what they are trying to ask. So if somebody can share a very accurate recall of this question with answers, I'll be happy to give the answer and reference. Coming to the next, post-esophagectomy, dark brown colored fluid on post-op day 2, fever, tachycardia, features of sepsis. So that is most likely leak or conduit necrosis, because a gastric conduit has been done. So this is a reference which I have got from Shackelford. So in conduit necrosis, a suspected anatomic leak, you always go for a contrast study. You do not do surgical exploration immediately, you do not do echo, you do not observe this patient, you always do investigation to rule out. So you do a contrast study that will help you in understanding what is the cause and if there is any leak or there is complete disruption of the anastomosis. So in this answer should be contrast study. Moving on to next, that is a 4-year-old child with sudden onset right testicular pain, with right testis was elevated, tender, urinalysis was normal. So very easy, straightforward answer is torsion of testis. Then that should be the answer, because DOR or Toupet are not associated with gas bloat. Neeson is associated with gas bloat syndrome. DOR and Toupet are partial fundoplication. It is never associated with gas bloat syndrome, which is not a feature of damage control resuscitation. So we try to maintain the blood pressure below 90, that is a permissive hypotension. So according to me, D, that is maintaining blood pressure to keep MAP above 90, should be the answer in this case, which is not a feature. Moving on to the next question, that is regarding a congenital or a pediatric varicocele. Now I have not been able to find a correct reference for this, so I'll not be able to tell you what may be the correct answer for this. So if you can find a reference for this, please let me know so that I can share with the other students also. Now moving on to a next, female with a 4 centimeter breast tumor with diffuse microcalcification, node is negative for tumor. So it is an early breast cancer because the size is 4 centimeter, but it is associated with a diffuse microcalcification. That means that it is a multicentric disease. So you never do a breast conservation surgery, but it is an early stage disease. So you can go for a MRM followed by a APBI or a partial breast irradiation, according to me, and the reference from shorts, the answer should be a MRM only. Moving on to the next question, that is why is lung abscess more on the right side, very predominant and easy answer, because the right bronchus is more shorter and wider and it is more straight, so compared to the left side. So any foreign body, any infective foci will travel faster and first to the right side than the left side. Moving on to the next, that is what procedure is this. So if this was the question, then it is a very straightforward, that it is a Roux-en-Y gastric bypass, wherein we create a small pouch and we do a gastrojejunal anastomosis, and you do it distal jejunostomy. So the answer should be a Roux-en-Y gastric bypass for this image if this was the same. Moving on to the next, 35-year-old, neck swelling increasing last 10 years with recent onset hypertension with thyroid swelling, pheochromocytoma, adrenal swelling. So it is more likely to be a meant to be syndrome, because only medullary thyroid cancer and pheochromocytoma. So what is the advice for the offspring? So this is a recall what I've got from you guys. So if it is a meant to be for the offspring, the answer should be prophylactic thyroidectomy before 1 year or at the age of 1 year. So according to me, that should be the answer. Risk of recurrence after nipple sparing or skin sparing mastectomy, to be very honest, I have not been able to find any reference in Daly, Sabiston or shorts for this. So I am very unsure now the last few questions, because I am telling you I am unsure, because the questions I don't know from where they have been picked, basically because it is also tough for me to give you the answers for the same, and I can understand how tough it must be for you to answer these questions. So really apologize to not being able to find an answer for this, but I'm trying my best to find the answers for the question which I have mentioned that don't have the answers. Moving on to the next, that is a patient with multiple comorbs, elevated total leukocyte count with jaundice, upper quadrant tenderness, so that is pain, jaundice and TLC, so sepsis, so you can suspect fever, so that is most likely to be cholangitis. So next step should be antibiotics. You give antibiotics first and then you do a biliary drainage within the next 24 hours. You do not wait for 3 to 5 days. You should always go for a biliary drainage as soon as possible with antibiotic coverage. So if there is any obstruction or any cholestasis also, it will resolve. So you should always, according to me, the answer should be antibiotics followed by biliary drainage within 24 hours. Now, growth hormone excess tumor with intraventricular bleed management. Now, if this is the question, that is a growth hormone excess tumor, that is a pituitary tumor with intraventricular bleed. Now, if this is the one which I have already discussed earlier, I am not really unsure about what the question is, so I will not be able to discuss this. Moving on to next, big pituitary tumor which is compressing over the optic chiasma, approach for surgery. Now, basically you go for a transsphenoidal approach for pituitary adenomas, which I have seen in the literature. But as it is a very large tumor which is compressing over the optic chiasma, according to the articles what I find, the best answer according to me should be anterior cranial fossa approach, because it is a large tumor and you need to go near the optic chiasma because it is a very big tumor. So according to me, the answer should be this. If there is just a pituitary tumor has been given in the image what you guys have found in the exam, then transsphenoidal can also be the answer. But being a big tumor compressing over the optic chiasma, according to me, in what I found online in the various articles, answer should be anterior cranial fossa approach. That is, you do a craniotomy. Now, if this was the image with a swelling in the back, that is most likely a lumbar hernia. In clinical examination, I have not been able to get accurate options for the same. So if it was a cuff impulse, reducibility, and in the 12th rib border, I think that should be the answer if it was a clinical examination was asked. So according to me, that should be the answer. Ulcerative colitis, 4 bloody stools if associated with dysplasia. The ideal management according to me should be surgery. In dysplasia, you don't go for observation or antibiotics. In dysplasia with ulcerative colitis, you always go forward with a surgery. That is the ideal management. Pancreatic pseudocyst, whether to do a cystogastro or a cystojejunum, it depends not on the patient's preference, not on the base of the duration of the cyst. It depends on the CT scan and where the cyst is exactly located, whether it's near to the stomach or near to the jejunum. So the answer in this case should be according to the CT scan and the location of the cyst. Hirschsprung disease, what is a true statement? Very easy, straightforward, constricted aganglionic segment with a dilated ganglionic segment. That is, the ganglionic segment proximal is dilated, distal or the aganglionic is constricted. So according to this, the answer is A. 3 sign, very straightforward, it is seen in coarctation of aorta. So moving on to the next question. Elective splenectomy, Ryle strip pulled out, postoperative 2, develops vomiting, abdominal pain, distension. Very easy, straightforward, it is acute gastric dilatation. Because post splenectomy there is chances of gastric stasis and dilatation. So if a patient in the postoperative period presents vomiting, distension, you should always suspect first acute gastric dilation. So in such scenarios, always suspect the most common and simple diagnosis rather than complicated. This was the one which I was mentioning earlier, that is regarding surgery for GERD, which is a true statement. All except is asked. Gas bloat syndrome is seen with toupee. So if gas bloat syndrome was asked with toupee or DOR, then that should be the answer because that is incorrect. If a patient with pain in fingers with exposure to cold, immune investigation were normal, what will you advise the patient? Now, very confusing options given by all of you in the recall, but what I have been able to gather is that if the option had that she has more risk of connective tissue disorder, that should be given as an advice to the patient, because you cannot say the patient is having Raynaud syndrome and will develop. The patient is having Raynaud disease, but if she is having Raynaud syndrome or not, we are not sure. So you should not advise that. You cannot just advise that the patient may develop connective tissue disorders. She is not having scleroderma, she is not having autoimmune disease because immune profile investigation is normal. So according to me, the answer should be B. Moving on to next, lymphocytic thyroiditis, very easy, very straightforward. Most common antibody found is anti-TPO antibody. So that is for Hashimoto thyroiditis. Now, ulcerative colitis with presence of TSC, if this was the question, the options what you have mentioned is I have not been able to get the accurate recall for this. So the last set of 50 questions, nearly 4 to 5 questions are such that I have not got proper recall, or if the recall what you have given you telling correct, I have not been able to find a proper reference for the same. Moving on to the next, that is donation for renal transplant. Contraindication is all except. So according to the options given, GFR if it is 80, then you can easily take. GFR less than 70 is a contraindication to living donation. More than 80 is not a contraindication. ERAS, which is not true. Now all of you have told that this were the option, that is early recovery, less readmission, less pain, shorter stay. According to me, all of them are true for ERAS. There are not more readmission rate because of the ERAS protocol. So if this are the option, I feel recall is incorrect, because according to me all the 4 are correct. Prophylactic colectomy with ileorectal anastomosis in Lynch syndrome, I have confirmed it is not FAP, it is Lynch. Then you always go for a rectal surveillance. So if rectal surveillance is not essential is the option, it is incorrect. So that should be the correct answer in this scenario. This is a reference which I have taken from shorts. Many questions from short this time. Now patient with burns, 4-year-old child. Now again many confusion regarding the recall, but according to the options given, if the option was ringer without dextrose, that is the answer according to Sabiston. That is, if the child is younger than 2 years, then you should give 5% dextrose with ringer lactate. If more than 2 years, then you should give ringers without dextrose. So that is what is mentioned in SABI. Now gastric outlet obstruction, very straightforward. The answer is isotonic saline with potassium supplementation. Now this is all regarding the recall in this session. Now many questions, I am really sorry I have not been able to tell you the correct reference or correct answer, because the recall in this set of questions, it is very tough. I can understand, even I would not be able to recollect all of them. I will thanks all of you who have been sending this question for the recall session, and a great effort from you all, and I hope this helps you to get a picture. I know I will not be able to get a very accurate picture regarding where you stand or how you have performed, but just get a clear tentative idea regarding your performance, and don't worry about what is going to happen. Result will be coming soon. I wish all of you the best of luck for the results. In this session also, if you have any doubt, if I have mentioned incorrect question, answer or the options, please let me know in the comments so I can correct it, and in the PDF which I'll be sharing very soon, I can give you a very accurate recall. So thank you for watching. If you have any doubt, any discrepancies as I mentioned, please reach out.